Well, hello everyone. This is the voice of Suzanne Fields. I am faculty and senior advisor for healthcare policy and financing with the Institute for Innovation and Implementation within the University of Maryland School of Social Work. I will be co-presenting today along with my colleague Sheila Pyries. Sheila, would you like to take a moment to introduce yourself?
Yeah, thanks, Suzanne, and hello, everyone. I'm a core partner of the National Technical Assistance Network for Children's Behavioral Health that is hubbed by the Institute at the University of Maryland. And I also play a role as a senior consultant to the Center for Healthcare Strategies, Child Health Quality, and Children in Managed Care Programs, and have the pleasure of co-hubbing the network's work with Suzanne related to policy, system design, and financing.
We are very glad that you all are joining us today as we look at our work with national experts around pediatric care integration best practices. And today we'll be talking about our consensus findings from an expert panel. Our webinar is supported by the National Technical Assistance Network for Children's Behavioral Health through funding from SAMHSA. This is the first of a 5-part webinar series we will be holding. Today we'll provide an overview and context as well as a presentation of the findings from an expert panel we held. In August, we will be focusing a deeper dive in terms of screening and consultative models. In October, we'll be talking about specific care coordination models for children with moderate to intensive behavioral health needs. And then we'll have 2 more webinars pending specific dates yet. We'll be announcing those shortly, specific to early childhood as well as to peer support. So we welcome you to stay tuned, visiting the website, getting information through the TA Telegram about the 5-part series and those upcoming webinars. Specific to today, what we are setting out to do and dialoguing with all of you is understanding how the needs of children, youth, and young adults with behavioral health conditions are different than the needs of adults with behavioral health conditions. Learning about those most effective integrative approaches for those children and youth, understanding the recommendations from the National Expert Convening, as well as then learning about those specific approaches from states, counties, and other localities that are effective for integrating physical and behavioral health services and supports for children, youth, and young adults. And with that, why don't we go ahead and turn to an understanding of the population and contextual factors and issues to best meet the needs of this population. Sheila?
Thanks, Suzanne. And this is information that you all may be familiar with already, but we feel it's important in a lot of these meetings, including with the expert convening we brought together, just to kind of review what we know about the population of children, youth, and young adults with behavioral health challenges. And as you know, the Centers for Disease Control and Prevention estimate that 1 in 5 children and youth will experience a mental health disorder in a given year, and 1 in 10 is estimated to meet the federal criteria for having a serious behavioral health disturbance, which is defined as having a significant impact on a child's ability to function socially, academically, and emotionally. And then others have estimated that 1 in 6 children and youth have mental health challenges that do not meet the criteria for a diagnosis, but who need support to address emerging risk issues, particularly true for very young children, birth to 5, who either don't meet the criteria for a diagnosis or for whom neither providers nor families, they may be reluctant to label a child at such a young age. If we look at this next slide and think of it as both a prevalence and utilization triangle, so let's say this triangle represented all children in your state, 80% of them, based on prevalence data, will not have a need for specialty behavioral health care, but some 20% will. And depending upon demographics in your state and or county, 2 to 5%, could be even a little higher, are children that have serious and complex behavioral health needs, are typically multi-system involved, at risk or in out-of-home placements. And then there's that group of children that's at very high risk of kind of moving to that top of the triangle. From a utilization standpoint, what happens too often is that that relatively small percentage of children at the top are using the bulk of the resources because they're using a lot of out-of-home facility-based care like psychiatric inpatient hospitalization, residential treatment, and that is leaving very, very little for home and community-based services and supports, and almost nothing for prevention and universal behavioral health promotion. So a lot of the efforts in states are trying to intervene earlier, kind of, turn this triangle on its head to a certain extent. It's a contextual issue that I think all states and counties grapple with. These data that I'm about to review are from a study that I've been doing with the Center for Healthcare Strategies with 3 waves of the Medicaid max data, which is all children in Medicaid, so some 30 million children in Medicaid. And we've been looking at how they use behavioral health care and by type of service and what the expense is associated with that use. And we can also disaggregate those data by race, ethnicity, gender, age, and also aid category, so TANF, children in foster care, and children on supplemental security income. So about 11%, it's just a little under 11% of children in Medicaid use behavioral health care. That includes both behavioral health services with or without psychotropic medications and children who are using only psychotropic medications without services. That 11% of children account for 36% of all Medicaid child expenditures. And their mean expense at a little over $10,000 per child is 4 times higher than for children who do not use behavioral health services. The mean expense for children in foster care runs about 5 times higher, and for children on supplemental security income or state disability criteria, it runs over 6 times higher. But even expense for children who are enrolled in Medicaid through TANF is twice as high as for children who do not use behavioral health care. And so while the rates of behavioral health use are higher, much higher for the foster care and SSI populations, there are so many more children enrolled in Medicaid through TANF, like 94% of the Medicaid child population, that you can't ignore that population when you're looking at trying to put together effective care integration or care coordination approaches. We also looked at the top 10% most expensive children. They have mean expenditures of almost $47,000. That expense is driven by the use of behavioral health care, not by the use of physical health care. And that's an important distinction from adults, for example, with serious mental illness, where their expense in Medicaid tends to be driven by their use of physical health services because they have very high rates of comorbid physical health diseases, like heart disease, for example. So we did look at, we used the chronic disability payment system that was developed at UC San Diego, mainly for adult populations, but it was all that we could find, and looked at the prevalence of comorbid physical health conditions among children who use behavioral health care. And most children, 60%, do not have comorbid physical health conditions. Of those that do, there's a high prevalence of things like asthma, which, in the grand scheme of things, are relatively lower cost to manage. And there was a very low prevalence of high-cost conditions like you would find in the adult population, heart disease, cancer, etc. Having said that, however, children in Medicaid who use behavioral health care are not as healthy as children in Medicaid who do not use behavioral health care, and children in Medicaid are not as healthy as children who are not enrolled in Medicaid. So there's, for all sorts of reasons, it's important for care integration and coordination with primary care, between primary care and behavioral health. The children who use behavioral health care, these diagnoses that are in red at the top haven't changed in the 3 waves of data. The most prevalent diagnoses are ADHD, conflict disorder, and mood disorder. PTSD at about 6% of children receiving that diagnosis, probably a little low. One can speculate, and as systems become more trauma-informed, that may go up. Children with a diagnosis of psychosis at little under 3%, that has not changed. It's very difficult to use diagnoses as a way of sort of organizing care and integration approaches for children, because diagnoses for children often change, unlike with the adult population. And you will find many children with a diagnosis, for example, of ADHD, using very high-end services. So you can't, for example, just say, oh, we'll look at youth with a diagnosis of psychosis, and that will be the population we focus on for care integration or coordination. That's not an approach that works well for children. The other thing that that we sort of grappled with also in the expert convening is that children, youth, and young adults, of course, are not a homogeneous population. They differ in age from very young children to youth who are transitioning, emerging adults. Many are involved with multiple child-serving systems, child welfare, juvenile justice, special education, for example. There are many different types of social factors such as poverty and adverse childhood experiences that can impact health and health outcomes. And of course, like the rest of the population, the child population is very diverse. So these are all factors also in thinking about care integration approaches. And kind of most importantly, children and youth, particularly those with serious behavioral health conditions, they're a distinct population from adults with serious mental illness. As I said, they don't have the same high rates of comorbid physical health conditions. They are multi-system involved in a way that adults are not necessarily, in the sense that children involved with child welfare, juvenile justice, and special ed, those are systems that have legal mandates to serve children. And many are also providing or screening, either providing behavioral health care or screening children for behavioral health services. So it's, from a care integration standpoint, coordination with those systems is very important. The diagnoses that children have are different from adults. You don't find, as I said, psychosis or schizophrenia so much, in the child population. Somewhat in an emerging adult, youth, and transition population, of course, more. And sort of every evidence-based practice for children focuses on the entire family, and that has implications for care coordination ratios, because that takes more time to work with other systems, work with the family. There may be siblings, all of which can have a bearing on health outcomes for a child, behavioral health outcomes. And so that has implications for care coordination ratios and rates. The American Pediatric Association has documented a high unmet need for care coordination for children with behavioral health conditions. And there's a particularly high unmet need for children who have significant behavioral health challenges that that are not met by the usual, that need isn't met by the usual approaches. So what are the usual approaches? There's traditional case management. There is care coordination provided by managed care organizations. There are health home approaches. Those that are designed more with the adult population in mind don't really do a great job with the child population. So if we look at Missouri, not to pick on Missouri, but they were the first out of the box in terms of a health home state plan amendment, and I think they would also agree that it was designed initially with an adult population in mind, but you can't just do a health home state plan amendment for adults. You must do one for children as well. And their care coordination ratio is, at the time of the development of this, they may have gone up or gone down a little bit on this, but it was 1 to 250, one care coordinator for 250 persons. Wraparound, best practice, Fidelity practice, is one care coordinator for 10 children. Payment rates, the Missouri health home rate was $78 per child per month, per person per month. Again, that may have gone up. They may have adjusted it for children versus adults, but it won't have gone up nearly significantly to the extent that we saw wraparound rates across the country when we did that kind of surveying. We found a range in a Fidelity wraparound approach of $780 per child per month up to $1,300 per child per month. So you need an approach for this population of children with significant needs that is based on evidence of effectiveness, that's largely face-to-face, where there's an intensity of involvement with families, with other systems, etc. So I'm going to stop with that kind of contextual information and turn over to Suzanne to talk about integrated care concepts.
Great. Thank you so much, Sheila. And so what we've just done is kind of laid a foundation for understanding the needs of the population. I'm now going to turn to highlighting some concepts from the literature, both formal peer-reviewed research literature as well as gray literature, about concepts and definitions of integrated care. So in examining the literature, it's become very clear that integration occurs at different levels. That term is used to mean different things. If you think about it in kind of two buckets, we have integration of behavioral health with physical health kind of occurring at a financing or administrative structure, more of that delivery structure. And then we have integration occurring at the practice level, what practitioners, primary care clinicians, behavioral health clinicians are doing. And so we see kind of those two groupings or those two buckets related to integration concepts in the research literature. And we know different things about how those two buckets or those two kind of ways of thinking about integration. We know different things about its implications for children. So as it relates to integration of behavioral health and physical health at that financing or those structural levels, a lot of what we know actually comes out of the Healthcare Reform Tracking Project, which Sheila and others were a part of about 15 or so years ago. And from that large-scale review of the Healthcare Reform Tracking Project, they found that less attention was actually paid to children's behavioral health services within those kind of integrated financing and administrative models. Now, this information occurred before a lot of the changes we're seeing in our delivery mechanisms now. It could, of course, be different. But as we think about what we do know about integrated structures at that financing level, the Healthcare Reform Tracking Project raises for us some key considerations to keep in mind, some key learnings specifically for children with behavioral health needs, that those services, those constructs, children's behavioral health just did not work as well within those integrative approaches at that time. As we also think about the terminology of integration or how integration is focused at the practice level, we see that there are a myriad of activities that are occurring at the practice level that are talked about in the literature. Those could be related to screening in primary care clinician settings, coordination of services through a myriad of different approaches such as medical homes or health homes related to the CMS initiative of health homes. There are consultative models where behavioral health experts provide consultation to primary care practitioners. We have efforts to co-locate behavioral health and primary care together. And then, of course, there are a host of team-based care approaches that are also discussed in the literature regarding how teams of people across different expertise work together. Additionally, what is also clear to us is that the terms that are used in the field do not necessarily have a single definition. Terms such as coordinated care or integrated care all have different definitions in the field or are seen as synonymous with integrated care. Oftentimes we saw in the literature that the term co-located care was seen as synonymous with integrated care, though in many ways it really was separately siloed, separate medical records, kind of separate practices, separate treatment plans, even within those co-located. So there wasn't necessarily integration. Many organizations have really tried to take on these concepts and tried to help provide further clarity to the language that's used in the field. We looked at over 15 different definitions in the expert panel. Here, just highlighted for you, are just a few of the types of definitions we looked at and efforts to provide clarity. As you turn to our full report, you'll see all of those in their entirety. What you see within these is there are many commonalities to the definitions, but we continue to see that there are many differences in how the field is continuing to talk about care integration. And what that means operationally is that we're seeing differences, and it's difficult to know what's actually happening within some of these care integration efforts. Additionally, as we looked at the literature, what became clear is that there was a lack of consensus about the most effective integrative approaches for children. Much of the literature in this area of integration has been focused on adults with serious mental illness or adults with serious mental illness and serious physical health conditions. And then where there was a focus on children, it was often on children who had serious medical conditions, not necessarily dedicated to this population of children with the range of behavioral health conditions. It became clear that much less was known about what strategies are best for children with mild behavioral health needs, with moderate behavioral health needs, and with complex behavioral health needs. There's some promising information coming through on several models. But again, collaborative care, intensive care coordination, using Fidelity Wraparound, we have evidence about their impact for segments of this, but more knowledge is needed to really understand which children could benefit from which approach at which time based on their unique needs. As we looked at the studies that informed the expert panel's recommendations, we also examined where where primary care could play a particular role in supporting children with behavioral health. We know that 75% of children with diagnosed mental health conditions are seen in their primary care setting. Many families are very comfortable with their primary care practitioner. And that as we think about the range of children who have behavioral health needs, there is data to support that children from differing racial and ethnic groups feel less stigma in those pediatric primary care settings than in those specialty mental health settings. So we know from the literature that pediatric primary care can play a really pivotal role in supporting children with behavioral health needs. The review of the literature also found that there are areas where primary care does struggle, that they may not be the platform by which all behavioral health needs for children could be best met. There were many studies that looked at how pediatric medical homes have struggled with coordinating the mental health needed care for children. One study in particular that the group looked at found that all behavioral health conditions except ADHD were associated with difficulties accessing specialty care through the medical home. So again, we saw studies that said, you know, medical homes did have some challenges. Those pediatric primary care kind of strategies didn't necessarily meet the needs of every child. Further studies also highlighted how children from different racial or ethnic groups, from lower income households with different proficiency for the use of English, also had some unique challenges in accessing or being part of medical home strategies. And similar findings were also found for lesbian, gay, bisexual, and transgendered youth as well. So as a basis for this, then, the expert convening wanted to really address and inform what care integration approaches would be best for this population of children, youth, and young adults with the varying behavioral health needs. Through the National TA Network, we convened a national expert panel, 40 experts from state government, health plans, health systems, provider organizations, trade associations, academia, family and youth-run organizations, and the federal government participated. These two slides just show you the organizations that were part of the expert panel. In the report, you can see full details about each of the experts' particular contributions and background. The purpose was to examine best practice approaches and achieve consensus on the elements of a care integration continuum with a focus on children, youth, and young adults with behavioral health challenges enrolled in safety net programs. We recognize that all children, regardless of payer, require care integration. Panelists focus on safety net enrolled children for the issues that Sheila highlighted in the population contextual factors, that these children often have higher needs for behavioral health than commercially insured children. However, and we'll talk about this at the end, the group recognized that many of its recommendations would be applicable to all children. We reviewed numerous articles. I believe close to 100 articles were part of our initial review. The report focuses on 23 that really informed these sets of recommendations that the expert panel had. We looked at 5 key areas of care integration and focused recommendation in each of those 5 key areas. Understanding the population, defining effective approaches, defining meaningful measures to strengthen accountability and improve outcomes, including attribution of accountability. which is key to understanding value-based payment approaches. We also looked at those financing and value-based payment approaches. And finally, workforce, provider, and system-level training and infrastructure needs in order to deliver on the most effective models. Sheila, I'll turn it back to you to talk about the consensus continuum that the expert panel developed, as well as some of our key findings.
Okay, thanks, Suzanne. So what we tried to do was put together all of the recommendations into a graphic that kind of gave one picture. Around a care integration continuum, if we think of a total population of children, and across the continuum, first of all, everyone agreed that this continuum should be nested within common values and principles. And I'll, in the next couple slides, show you what those are. And that across the continuum, there should be availability of family and youth peer support and system navigators. And that the continuum, again, across the components of the continuum, should be measurement-based, so metrics across the continuum. So if you look at that, the box on the far left-hand side, for all children, pediatric primary care services that include promotion of social and emotional development, developmental and behavioral health screening, and family psychosocial screening with a broader focus on social determinants of health, which Suzanne will talk about in a second when she talks about screening. Those pediatric primary care services encompassing that comprehensive screening could occur in primary care settings, in behavioral health settings, in school-based or other community settings. The group decided that they really didn't want to get sort of hung up on where these components could be offered. In fact, they felt like they could be offered in any number of settings if the setting in question had the appropriate infrastructure to support these functions. So for children with an identified behavioral health need, if we go to the next box on the left, the group recommended that there be child behavioral health consultation programs, which include mental health consultation to primary care practitioners and to early childhood settings, such as preschool, Head Start, child care settings, that are coordinated with behavioral health. Again, child behavioral health consultation programs could be coming out of any particular system, primary care, behavioral health, out of a school-based setting, etc. For children with an identified low to moderate behavioral health need, the group recommended and came to consensus around the importance of team-based care. Again, and the full report talks about the kinds of infrastructure that's needed to support team-based care. And again, team-based care could be coming out of any setting. And then for children with significant behavioral health needs or very high risk, those children that are in or at risk for out-of-home placements, for example, the group recommended intensive care coordination using Fidelity Wraparound. So I'm going to give you some examples of, Suzanne and I are going to give you examples of a number of these as we go across the continuum. But let me first just address, and these values, again, are going to be very familiar to you, I would think. But the values were that they, things like being family-driven, youth-guided, strength-based, culturally and linguistically competent, LGBTQ welcoming, have a focus on continuous quality improvement, be trauma-informed. And so these were the values, and the principles is that there should be available a broad array of individualized and effective practices, And one of the things we found in our analyses of the Medicaid data is that, and one of the reasons we're looking at these data over time is that the larger delivery system environment has changed. For example, many more children are in capitated managed care environments. And one of the things we've seen is, I think maybe both because of more children being in managed care and also an emphasis on screening, that in the last wave of data that we looked at, there was a pretty significant increase in screening, particularly for very young children, and I'm talking about behavioral and developmental screening. But not necessarily, there wasn't a sort of concomitant increase in access to services. So, again, people come back to the importance of a broad array of services and supports, and that there should be true partnerships among child-serving systems between primary and behavioral health care and with the other child-serving systems, that there should be an orientation to promoting wellness and child development, including, of course, early identification. The care integration continuum should be data-driven and accountability-driven. And again, that's where that infrastructure piece is so important. The absence of, for example, electronic health record systems where primary and behavioral health providers can share data is a challenge. And care integration approaches need to be sufficiently financed and resourced so that you can have the appropriate care coordination ratios to actually produce good outcomes. And there should be effective monitoring and oversight. So those were the principles and values that people agreed on. The Family-Run Executive Director Leadership Association, FREDMA, has put out a nice graphic of their own on the roles for parent peer support, parents with lived experience, which also is applicable to youth with lived experience, based on the intensity of services a child needs or in which a family is involved. Everything from at the low end of the triangle, education for families, information and referral, outreach, all of those are roles that families could play in helping to engage families, up through providing peer support, providing respite, etc. So I'll turn back to Suzanne for a moment to talk about some screening examples.
Sure. So across the continuum, as Sheila was just highlighting, the role of parents, common principles, and common values, the final piece that's inherent across that continuum was a recognition of social determinants of health. So those conditions in the environment in which people are born, live, learn, work, play, that affect their health functioning and their quality of life. And so as part of that care continuum, embedded throughout those four kind of aspects of care that we just walked you through, is a recognition that social determinants of health need to be at every one of those four, in screening, in consultative models, etc. I'm just going to take you back for anybody who gets seasick quickly. I'm going to just take you back to that care integration continuum for a minute. So we have screening, we have consultative models, we have team-based approaches, and then we have approaches for those with the most significant needs, such as intensive care coordination using Wraparound. So Sheila and I now are going to turn to highlighting examples from states and localities of each of those four. And so the first one that I'll talk about is developmental and behavioral health screening. So as you all know, in January 2015, CMS added emotional and behavioral health assessment with scoring and documentation in response to the ACA's federal mandate. So these are kind of included mental health services as part of that essential benefits package and as part of those strategies that CMS was messaging to states to include. We have examples of system-level state purchasers kind of strategies to incorporate developmental and behavioral health screening in their approaches for their Medicaid populations. One of those is in Massachusetts. Their Medicaid program called Mass Health requires EPSDT screens to incorporate looking at developmental and mental health needs. They have a set of, or kind of a suite of tools that primary care clinicians can select from as part of that developmental screening process. And then Massachusetts Medicaid actually tracks if there were kind of positive or negative screens as it relates to the needs of those children who were screened. Another example, again, is North Carolina. They recommend structured screens for emotional and mental health as part of their EPSDT requirements as well. And we have additional information about what North Carolina is doing by this link. All of these links are live, so you're welcome to touch on those as you're listening. They'll pop up in an additional screen alongside this platform for you. And a third example is, of course, District of Columbia, which has managed care, so their Medicaid managed care requirements to ensure that all children enrolled in Medicaid managed care receive mental health screenings as well. So there are numerous examples of those kind of statewide efforts within Medicaid to incorporate that. The second aspect of the expert convening's recommended continuum was consultative programs. So here for now, just highlighting for you Massachusetts Child Psychiatry Access Program. This is a consultative model in which primary care clinicians can reach a psychiatrist within 30 minutes for rapid consultation. So pediatricians may have somebody in the office. That person can't stay in the office indefinitely for consultation. You want to support them while they're there in front of you. So Massachusetts has set this up where a primary care clinician can reach a psychiatrist within 30 minutes for consultation. And that consultation could be about a Medicaid issue, about kind of medication that the primary care clinician may be responsible for, about wondering if medication could be an important kind of piece or point and, of treatment. And then finally, through MCPAP also, are independently licensed mental health clinicians, which can operate as resource and referral specialists for that family. One of the major concerns that primary care clinicians have is once they've identified a need in one of their patients, they don't necessarily have the resources or the ability to ensure that that person gets linked. And that MCPAP model is structured in order to provide that additional support to ensure that those patients of that primary care clinician office do get linked to treatment. And in fact, our second webinar, which I mentioned at the onset of today's webinar, our second webinar occurring next month is going to do a deep dive into consultative models such as MCPAP, which I've just talked about. As another example, Minnesota, they also have a consultation program approach. Theirs is focused on that 0 to 5 population, again, thinking about their state's kind of priority areas and concerns. They worked across departments of education and health to establish kind of a statewide effort to focus on that 0 to 5 population around prevention screening, early identification, as well as targeted interventions for that population. Sheila, I'll turn it back to you to talk about team-based care approaches.
Right. So Montefiore Medical Center is really a health system in serving children in the Bronx in New York. And they're an example of a health system that really has implemented most of the components of the care integration continuum. So their population focus is about 90,000 children who are served by 20 pediatric practices. And they reach about a little over 13,000 children with behavioral health needs. And, you know, if you did the math, that's close to it's about a 15% penetration rate, which is higher than we found at a little under 11% when we looked at all Medicaid children. And so what do? They do universal behavioral health and developmental screening, and they also use ACEs, Adverse Childhood Experiences screenings, and they pay attention to the psychosocial issues around the families and parents and caregivers. So they're you know, doing sort of what was recommended in that first box around comprehensive screening in those primary care practices. For very young children, birth to 5, they're implementing Healthy Steps, which is an evidence-based early intervention program. And then for children older than 5, they've implemented what they call the Child and Adolescent Psychology and Psychiatry program, where they're implementing modularized treatment for ADHD, anxiety, conduct disorder, depression, and trauma. So they're implementing evidence-based practices like trauma-focused cognitive behavioral therapy, motivational interviewing, etc., providing on average about 4 to 6 sessions. They're reaching that population of children with an identified behavioral health need who have mild to moderate behavioral health challenges. And they are referring out about 10% of children whom they identify through their screening as having a behavioral health need, but more severe and significant, more complexity, more system involvement than they're able to handle. And what's interesting is that they're also receiving shared savings from they're organized as Montefiore is an accountable care organization, and the children's mental health integration program is actually receiving savings from the adult side because they didn't yet have they weren't really serving the highest need population of children for whom you can, reduce use of facility-based care, et cetera, and show a savings. But they are receiving savings from the adult side, recognizing that when you catch problems earlier with children, you can often avoid more costly issues as children enter adulthood. So it was an interesting example, and they use team-based care in their mental health integration program, so that was one example. Another example people talked about, as Susanna mentioned earlier, was collaborative care management, which came out of working with adults, but it has shown some good results for adolescents with depression who are using office-based services. And again, it's a team-based model. It's led by a primary care provider. And it's a measurement-guided care plan based on effective practices and incorporates cognitive behavioral therapy in partnership with behavioral health providers. And so it is, it's an effective approach for a particular subpopulation within the larger population of children with behavioral health challenges. The National Wraparound Implementation Center, which is based at University of Maryland, is developing a model called FOCUS that's really geared toward children with moderate and kind of at-risk populations who haven't yet risen to that need of having a complexity of problems, but need more care coordination than a child with just sort of mild behavioral health issues. And So focus is also intended to be implemented within a system that has intensive care coordination using wraparound for children who have complex needs and are in or involved with at risk for involvement with multiple systems. Interestingly, if we go back a moment to the Montefiore model, in New York is experimenting with health homes, and they are looking at perhaps integrating Fidelity Wraparound as their health home approach for children. And if that were in place, then Montefiore could be partnering with that health home and have a place for that 10% of children that they're having to refer out. So they have sort of the total system in place. Focus as an intermediate care coordination approach is still it's values-based, so it's really reflecting the expert convening recommendations. And those values are basically the same as those I went over earlier and very resonant with the values of a wraparound approach. And encompass a look at the social determinants of health, developmental issues, et cetera. But they're not including children that have that intensity of multi-system involvement and that are either in or really high risk of out-of-home placement, where you're also looking at things like social determinants of health. So the values are they're the same, but it's the intensity of a child's needs and the intensity of the care integration approach that varies. So National Wraparound Implementation Center is working with Nevada to implement focus, and Nevada is also implementing Fidelity intensive care coordination using Fidelity Wraparound for children that have complex needs and that are in out-of-state or out-of-home placements. And the idea of focus is to create, in Nevada, is to create a consistent care coordination model that's values-based and informed by evidence-based components, if you will, across juvenile justice, child welfare, and behavioral health. And to update traditional case management practices using this evidence in order to achieve better outcomes. So if you think of it as sort of analogous in a way to Bruce Chorpita and his colleagues managing and adapting practice, where they're taking the components of evidence-based programs, those elements, and incorporating them into outpatient practice. That's kind of what the National Wraparound Implementation Center is trying to do with focus, applying those effective elements to care coordination, care integration. So the group really did not identify, oops, I knew I would do that. The group did not really identify an effective intensive care coordination approach other than wraparound, Fidelity Wraparound, for children that have complex, serious behavioral challenges and are involved or at risk for involvement of out-of-home placement. Wraparound was the only one around which we could find evidence in the literature or that the expert convening came up with. Wraparound is a team-based approach, as all of these are that we're talking about. It does look at social determinants of health. It looks holistically at the child and the family. It works across systems. And it's not a service per se. It's an approach to care coordination and service planning. Wraparound, as you know, is associated with improved outcomes. There have been a number of studies, and the National Wraparound Initiative, has those on their website. But both improvements in clinical and functional outcomes, reduced recidivism and juvenile justice involvement, increased rates of permanency and placement and reduced placement disruption in child welfare, reduced costs associated with residential treatment, and greater family and youth resiliency. States are structuring wraparound in sort of one of two ways, either through care management entities, which are organizations that are set up to do this kind of work or contracted to do this kind of work, and like New Jersey, for example, with its care management entities that are locally based and are contracted by the state to provide intensive care coordination using wraparound. And New Jersey also has built on that structure for its health home for children with serious behavioral health challenges. Or states are embedding high-quality wraparound teams in support of organizations such as community mental health center or school-based health center like Oklahoma, which is doing that through its health home teams, which are within community mental health centers and other behavioral health organizations within Oklahoma. So Massachusetts, as one example, provides intensive care coordination using wraparound through locally based care management entities, which they call community service agencies, and they ensure there's a child and family team plan of care. They provide that dedicated care coordination at low ratios. They provide access to peer support and are looking at utilization and outcomes at that child and family level. Oklahoma has a health home model. Now, this is an approved Centers for Medicare and Medicaid Services health home state plan amendment, in which Oklahoma took the evidence about what they knew worked around intensive care coordination for adults and for children, rather than trying to apply one generic approach to both. So for their adults with serious mental illness, they use an ACT team approach. For children with serious emotional challenges, behavioral challenges, health challenges, they use a Fidelity wraparound approach. And this is an interesting sort of graphic that we're looking at, in that they have patient-centered medical homes in Oklahoma, and so they wrote in requirements that the health home, which is based, the behavioral health home, which is based within community mental health centers or other behavioral health providers, that there is consultation with the primary care practice, and in both ways, going back and forth, that they're making sure that the child receives the screening that needs to occur through early periodic screening, diagnosis, and treatment, and that primary care medical home is also handling referrals and overseeing specialty physical health care. The behavioral health home not only is working collaboratively with the patient-centered medical home, but also creating that one plan of care in concert with juvenile justice, child welfare, education, et cetera, and is also looking holistically at social determinants of health. So it's looking at where they can link families to, food supports and housing supports. They've added wellness coaching into their wraparound model, and so they're doing a lot of wellness activities, and it's, of course, very much of a team-based approach to care coordination. What's interesting about the Oklahoma model, as I was saying earlier, that to support the low care coordination ratios that are needed in a Fidelity wraparound approach and the intensive work that has to occur with families and other systems, you have to have a sufficient rate. So if you look at this graphic, you'll see that the rates for children are higher than adults, actually significantly higher. And so the rate, for example, and they have also two levels of care coordination, moderate intensity and high intensity. And their moderate looks a little bit like a focus approach. It's taking those wraparound principles and elements, so it's values-based, but the intensity of involvement isn't as intense as a Fidelity wraparound approach. And So for their high intensity, which is their wraparound, in their rural regions, the care coordination rate, which is the one at the very bottom, is a little over $1,000 per child per month. That's the care coordination rate. That does not include services. It's the care coordination rate. In their urban areas, it's a little bit lower. It's about $865 per child per month. They decided to increase the rural one because of things like transportation, etc. And, you know, you compare that rate to the adult rate in the rural region is about $454 per person per month. Okay. So I think on that note, we sort of walked through the care integration continuum. I wanted to say that in the October webinar series, we'll be going into more detail about team-based care coordination, care integration models, because, you know, this is just an overview we're trying to do. And we'll bring presenters on from the examples that we'll be using. And yeah, so I think I'll turn it back to you, Suzanne, if you want to facilitate discussion, questions, etc.
Thank you, Sheila. So we do have time for discussion, either clarification questions that participants may have about the expert panel and the findings, but most importantly, as you consider these concepts for potential application to your own state or locality, certainly would encourage discussion with us and the other participants on the call about those issues you may be struggling with. There are two ways for this to occur. The first is the public chat box where you can submit a written question. So you're welcome to use that public chat box and submit your questions to us. And we can also go ahead and open the lines so that we could have a direct dialogue and people could just ask a question or raise an issue that they're grappling with in their own state or locality. Tiara, could we make sure we could go ahead and open everyone's phone lines?
Yes, before I go ahead and open the phone lines, I do just want to remind the participants that you will be unmuted. And so if you prefer to not participate in the verbal discussion, please go ahead and mute your telephones by using your telephone's mute button.
Great, thank you very much. And it does look like everybody's line is unmuted. Is there anyone with a particular question that they would like to start off with, please? If you would just introduce yourself, say your name and what your question is. While people are considering or trying to unmute their own individual phones, Sheila, I did want to turn to one of the questions that we often get from states and localities is kind of the issues around mapping what they currently have and understanding how what they currently have is meeting the needs of children with behavioral health conditions or could be kind of further adapted, and then kind of understanding what they would need to grow or kind of consider adding in. And I know oftentimes, you know, as states consider what they currently have and do they really kind of meet some of these needs, how is it really being used in their system, they're often trying to understand what kind of data to look at, kind of how to articulate that. Do you have some specific recommendations for kind of that starting place for participants as they think about applying this care continuum content to their current systems? It's a big question, but you know, I'm trying to get at what we often get asked from states and localities.
Right. So it is a good question, and I do think it's important for a state to sort of map out. You can do it through a small stakeholder process, but to map out what if you took that care integration consensus framework, that graphic that we put up, and you look systematically at, okay, where are we doing screening? And obviously, EPSDT screens are required. What's required in those screens to actually, look at? Are we requiring comprehensive developmental, behavioral health, and screening that also pays attention to social determinants? That's one area to look at. Where else are we screening children where they're ending up in behavioral health care, or should be? Looking at care coordination. For example, managed care organizations are all contracted to do care coordination. They can delegate care coordination to a provider organization, for example, around subset populations. So they could be delegating intensive care coordination using Wraparound as one example, or collaborative care management for adolescents with depression to providers that know how to provide those care integration approaches. So what is going on in terms of managed care contracting around care coordination? What could be delegated to providers? What do our providers know how to do? I think that do we have mental health consultation programs? Are we doing early childhood consultation programs? You can kind of do that mapping, and then it's not only are we doing these things, but what is the quality of kind of what are the characteristics of what we are doing? Are they going to incorporate the kinds of values and principles that certainly the expert convening recommended as sort of critical to producing better outcomes? So I think there's that kind of mapping that needs to occur. I mean, targeted case management is a big one in states because most states are doing some type of targeted case management. It's not necessarily values-driven or tied to these kinds of effective approaches. It could be an opportunity for revamping targeted case management, according to these principles and effective approaches. So that's just sort of one example.
Mm-hmm. That's very helpful. Sheila, as you and I had, led this work with the expert convenings, we've grappled a bit with where to go next. Like, what are kind of the primary needs of localities? And I'm wondering, for participants who are listening, what challenges or recommendations you would have back to Sheila and I and the National TA Network about further considerations. Always the focus of our work is, how to support what you are doing to implement, to design, to lead services and systems that meet the needs of children, youth, and young adults. So I'm wondering if there are participants, if you have ideas, recommendations about things you're grappling with or things you're sitting with that relate to this report that we could further consider.
And Suzanne, it's Sheila again, and before folks weigh in on that, I just want to say that we do know that the field is kind of early along in coming up with care coordination approaches for that sort of mild to moderate group of children.
That's right. Well, I see one question actually, Patrick, thank you, which I think relates to, what we have heard is a challenge, and we were wondering if we would surface today, which is kind of levels of care coordination. Your question is specifically what levels of care coordination do NCOs generally provide? And I know that we have found that answer can vary by state, and that's part of what so we have some states that have, multiple levels of kind of care coordination, kind of along those kind of team-based approaches where they're thinking about low, medium, or high needs. We've had some states that have tried to define more than 3 levels, right? We have some states that are using kind of 2 levels. And I think that's also part of what, the Institute at the University of Maryland is trying to study with the focus level of care coordination for that moderate need group, which often can be very amorphous, kind of more difficult to define. We tend to have kind of a better sense of what's the presentation of children with kind of low behavioral health needs, what could be the presentation of children with complex behavioral health needs, and that moderate group can be somewhat difficult to define, right? Sheila, what other thoughts do you have about the levels of care coordination that are generally kind of seen or used nationally by MCOs and Medicaid?
Yeah, so, I think in general, MCO care coordination is telephonic, it's by email, it's with large numbers of people where there's, but they may be overseeing more, more specialized care coordination that are actually being provided not directly by the MCO, but by provider organizations. It does vary to a certain extent. It kind of depends upon, what the state has charged them with doing, but they're not really set up to provide an intensity of care coordination needed by children who have probably even moderate to serious behavioral health challenges for the most part.
Thank you, Patrick, for that question. Other questions that participants have, either through the chat box or phone lines are open. Sheila, I know we had just gotten a question kind of related to how to support your varying providers to understand, some of these differences. Oftentimes we find that there is a navigating perspective, the perspective of primary care and the perspective of behavioral health. And I know we were intending that this particular report from the expert convening would kind of provide a foundation or kind of level the playing field in terms of presenting literature that was inclusive of primary care and behavioral health research, both peer-reviewed and gray, again, to try to level the playing field, provide a foundation for kind of a common understanding. As we've kind of considered that, are there additional recommendations we have for participants on kind of supporting or furthering kind of that common understanding that needs to happen in states or localities to really advance these approaches?
Yeah, I think it's not just with providers, but with state purchasers like Medicaid or behavioral health authorities or child welfare for that matter. I think there is a need for a better understanding, which is why we often start with that contextual and population piece about the population of children, youth, and young adults with behavioral health challenges, and that they do differ from adult populations in some significant ways that have implications for how you structure care coordination. And I think that the other big education thing is that sometimes a state or providers think that they're implementing, let's say, Wraparound, and when you actually look at what they're implementing, they're really not implementing Fidelity Wraparound. And like any effective practice, if you don't implement it with fidelity, you aren't going to get the outcomes that you expect. And so I think it's both making sure that people understand the population and that these children, that they do vary, both in terms of intensity of need and the kinds of approaches that can make sense. They can be brought together these approaches through common values and principles, which I think our group was saying is really important, and helping providers understand how you operationalize principles like being strength-based and being, family-driven, partnering with youth, etc. So, I think all that's needed, and I think also we need to do a much better job on the infrastructure to support these care coordination approaches. So, payment mechanisms that will allow a provider to actually do Fidelity Wraparound, and data systems that support integrated care. So I just, in addition to the sort of training and capacity building that's needed.
Very good, thank you. Are there any other final questions? I'm aware of the time, so I want to turn us to wrapping up and highlighting a couple of things that are coming for you. Are there any other questions from participants before we do that? Well, we do want to thank you for participating today. The full report is available on our website, which you can access here. And as I mentioned at the start of the call, this is the first in a 5-part series. We have our next webinar coming up on August 14th at 1 p.m. Eastern Time. We have presenters talking about their screening efforts, their statewide screening efforts, as well as their consultative models for primary care and behavioral health. And then in October, we have a deeper dive at those care coordination approaches. And then in the winter, we're going to be talking about early childhood strategies. A specific date will be announced shortly, as well as the inclusion of persons with lived experience, peer support, parent peer support, and youth peer support in a subsequent webinar as well. And all of those details can be found at our website as well as through the TA Telegram. So we want to thank you for participating today, and we welcome your feedback and any questions you have. At any point, you can be in touch with Sheila or I. Today's presentation slides are available for download, so you're welcome to go ahead and click that download files button so you have that information. And we will also, in about a week or so, be providing an email follow-up to today's materials as well. So thank you again for participating, and have a good day.
Thank you.